Hello, my name is Wendy Prosser. I'm with JSI. Today's session is building a more resilient supply chain through design. And when we're talking about design and system design, what we're talking about is an evidence-based approach to analyzing and modifying the components of the supply chain in order to improve the performance and efficiency of the supply chain. Today, we're going to hear from three different presenters. The first one is Freddy Nkosi from, he is the country director of VillageReach in DRC, and he's been involved in the redesign process of the immunization supply chain in Equator province and the important factor of engaging stakeholders and government leaders. The second presenter will be Dr. Francis Mwansa from Zambia, who's been leading the process of redesign in the supply chain and coordinating a broad supply chain improvement effort in that country. And finally, Dr. Olamide Folorunso is the supply chain specialist from UNICEF Supply Division. And he supports countries' public health supply chain redesign initiatives across immunization, nutrition, and emergency. And he'll be talking about some analysis of design in 3 countries. Freddy, if you can take it away.
Thank you very much, Wendy. Good day, everyone. I'm so happy to be part of this conference. I'm going to share a little bit about the experience of DRC or VillageReach DRC in building a more resilient supply chain through system design. System design is a core business of VillageReach DRC as we aim to strengthen the health systems, working with government as our key or primary partner. So when we talk about the resilient supply chain, it is a supply chain which can withstand against economics, political, social, environmental shocks. So that is the resilient supply chain system. We would like to share a little bit of our experience in the DRC context. So how does a robust supply chain operate? There are a few elements working from the manufacturer to the last mile. So that is in the 4 boxes, a robust or supply chain, a system for supply chain, a planning and monitoring. So this is from the manufacturing side, moving to supportive legal, regulatory, and policy environmental level, leveraging supply chain. And this is something where VillageReach has been championing or leading the integration of programs, integration of resources with other partners to deliver supplies. For example, if vaccines should leave one province to a health district, taking a boat and TB treatment should also leave from the same province to going to the same health district. And we have malaria. Do we hand, for example, a district? We would prefer, for example, to encourage integration of programs, integration of resources at programmatic level so that TB drugs or HIV and malaria can be transported during the transportation of vaccines. We have been experimenting this in Equator province, where we transported essential medicines along with the vaccines. And more interestingly, we did a study where we realized, like, when we transport vaccines in, for example, a boat, the vaccines actually take only less than 25% of the boat capacity. So there is space available to take other health commodities. So that is the integration that we have been promoting, and that assist efficient supply chains, operation, and train human resources. Human resources are key for that supply chains because you can have the products, you can have all the resources, all the equipment, but if the people who are supposed to lead or supposed to manage the whole supply chain systems are not trained, they don't know the whys and the hows, it's going to be difficult to achieve the result you are intending to have. I will talk a little bit about the designing the next generation of supply chain, which is a VillageReach experience. So the next generation of supply chain is VillageReach flagship program, which we have been conducting or rolling out since 2017, starting, as Wendy said, in Equatorial Province. Now we move or we expand or scale to 4 new provinces, replicating the same experience. So the next generation of supply chain has 3 key steps. And the first step is the pre-system design workshop, and so that we get their buy-in and they are part of the process, because we don't intend to replace a government role, but we aim to support government efforts and making sure that any solution that we are designing will be transition to the government. So the first step, we conduct the training of data collectors, because those data collectors will be deployed to conduct the assessment of the existing supply chain systems at national level, subnational level, at all levels. There is a sort of the supply chain system existing, but in the case of DRC, most of the supply chain system that exists, we call it traditional because it cannot withstand against economics, humanitarians, or political shocks. For example, now the country experiences 2 outbreaks, Ebola and COVID-19. These 2 outbreaks put pressure on the health systems, put pressure on the supply chain. And if it's not resilient, you might win Ebola or COVID-19 battle, but you may sacrifice other programs, or you may sacrifice other health commodities. But a resilient system is the one that can, while attending to the new needs, can continue to serve the ordinary or existing needs. Then we do the desktop research on the performance of the existing supply chain. So we don't not only collecting the data, but we do the desktop research where we need to read the report, the previous report published by the government or other key stakeholders around the supply chains or around the health systems within the particular province or particular health district where the new system design will be implemented. Then the second step is the system design workshop, or the actual system design workshop, where we develop a new and optimized supply chain system. When I say we, in fact, we will work with the government officials and train them so that they will know the hows and the whys, and they will be themselves the designer and knowing why we should, for example, change the distribution frequency from a monthly frequency to bi-monthly frequency or to quarterly frequency. They will know, for example, why they should, for example, reduce 3 level of distribution, meaning provincial, district health facilities levels to just 2 levels of distribution, starting from the provincial warehouse directly to the health facilities. Then, because we want government buy-in, because we want this to be transition to the government in the long run. At the end of the system design workshop, we organize a validation workshop where we will call the provincial governor, the provincial health minister, and all other key stakeholders at the provincial level to validate the new and optimize supply chain so that they can own it, they can fund it, they can implement it. And again, the people who have been trained, they will be able to provide meaningful change when, for example, the context in which this, the system has been developed change after a couple of months or after a couple of years. Then the implementation of the new supply chain system, that's the third step. And during this implementation, we will create a network of champions. Those are the people who have been trained. Those are the people who have been trained by their peers. They become the champions and they can impart change to their peers within their provinces, but also outside of their province. To move very swiftly, the second point that I wanted to highlight, this is the elements. I'm not going to give all the descriptions, but these are the elements of the next generation of supply chain. There are three. The first one is, or the first category is enabling environments for a resilient supply chain system. So enabling environment, I spoke about a government engagement where we need to get the buy-in at all levels. Then the supply chain assessment and system design, which I just spoke about, and the transport route optimization, where we will discuss and see, for example, what is the best way to transport health commodities from the provincial level to health district A, to health district B, C, D, and so on, and also to the health facilities A, B, C, D, and so on. So we will discuss together with government officials and have a transport route optimization, which will be very cost effective and adapted to the concept, the context. I mean, the second element is the managerial, the second category. In this category, we are looking at the coordination mechanisms. What are the existing coordination mechanisms, especially around the supply chain, where they can make decisions? If they don't exist, then we can support the setting up of a coordination mechanism. But if it does exist, we can strengthen the existing coordination mechanism. The training component is very important, where the system design is only the entry point. But again, we need to strengthen the capacities of the people who will be taking charge of the supply chain. Then we have the supply chain leadership training in three modules. The first module, where they get the basic. The second one is capstone training, where they will come back after 6 months to report on the changes they made after attending the first training. And the third module is where they can be declared as the champions, and they can, in their turn, be providing support to other provinces or to other health districts. Then the performance analysis, where we can see how we can assess time to time the new and optimized supply chain system which we design or develop in a particular province. Then the last category is operational. At operational level, when we look at the health commodity distribution together with the champion to see, for example, should we do the direct delivery from the provincial warehouse to the health facilities, or we should, in some health districts, deliver the product first to the health district, then to the health facilities. Data collection, very important to enable decision makers at all levels to make informed decisions based on evidence. And supportive supervision, this is ongoing support we're having every time we provide or we conduct a distribution of health products. Then we will be conducting the supportive supervision to analyze the challenges where they are facing, develop a development plan together, and in the next visit we'll be revising the development plan to see if there have been any change made or if there are new challenges emerge, and see how best we can support them. I think maybe I can stop there.
2 minutes remaining.
Yeah. Okay, so these are some of the impacts in this specifically in Equatorial Province, where, for example, after implementing the supply chain, we have seen an increase in average monthly vaccine consumption of 22% compared to other health districts where the next generation of supply chain was not implemented. But also still in Equator, over 75% of the health facility had vaccine availability compared to the period just before the implementation of the next generation of supply chain. In terms of the costing, very important, the next generation of supply chain in Equator reduce up to 20% of the distribution of the supply chain costs by 20%. That's something which we received a lot of support from the government, looking at how they can continue, if, for example, they have to take over of the supply chain, how they can continue to fund with less costing systems. So, ladies and gentlemen, thank you very much for your attention. Thank you.
Thank you so much, Freddy. Those are quite impressive results from DRC. It's nice to see the improvements in the consumption of vaccines and reducing stockouts and improving stock availability, and of course, reducing the cost as well. We're now going to go to Zambia and hear from Dr. Mwansa on their process of system design. And I think you're still on mute.
Thank you very much. I begin by thanking my colleague from the Center for Infectious Diseases Research in Zambia, that's Cheryl Rudd, who we've partnered with throughout this journey of trying to build a more resilient supply chain through system redesign in Zambia. A number of reasons really prompted our desire to move in that direction. We did realize, having seen examples from other countries, the need to reduce the costs associated with supply chain, the need to improve stock management, reduce also the workload, or where possible, disperse it or redistribute it, where we needed to improve the efficiency of the system, appropriately also use the existing trained human resources available for immunizations. Also the need to increase, importantly, the coverage. By the way, everything lead to that. And also the need to have better visibility of stocks at lower levels. We've also had this long desire to have decisions made, almost all decisions made through data, and also to improve communication. So quite a lot of reasons why we needed to start finding efficiencies in our existing supply chain in Zambia. So this is what existed at, for quite a long time. And this is what exists nationally, except for the province that I'll discuss, that we have, of course, vaccines come in country, as we do not manufacture any. And then they have to go downstream through 10 provinces, 116 districts, to now about 3,400 facilities. A number of steps that we've taken along the way began with advocacy, and we're fortunate enough to have some support from a number of partners, key amongst them, that's VillageReach. So advocacy led to a number of technical working group consultations. We had a number of workshops, but one of them really brought to the fore the buy-in from stakeholders and started the discussion of different scenarios that would come in. Then we went on to look at data. Two key processes were involved in there: data collection and cleaning. And then we had to build or run the models, which was quite an iterative process because a few things had to be clarified. The results of which took us to the third stage, where we had a workshop to discuss then what the options were. And that also led to some discussions within the government system around decision making. With positivity all around, we moved on to do resource mobilization, which was hallmarked by the fact that there was a collective impact in terms of partnership, resulting in 4 partners partnering with the Ministry of Health. And each of these processes took about that much time, as we can see on the panel on the right side. And so regarding the options that we selected, here are a few things that the options brought. One is that we had to discuss potentially the changing of the frequency of distribution of vaccines. In the routine system, it's a quarterly distribution. But for the system redesign, we're thinking about a month and a half to 2 months. We also needed and discussed the need to optimize the use of the existing transport through the different routes in country. We also had to discuss the change in the hierarchy of the supply chain, be it from province to facility or district to facility, or having regional hubs to these facilities. We also agreed that we needed to ignore administrative borders if we really had to optimize what we wanted. So these the results of what we got from the modeling. What we see in the first row is really the existing system. The existing system also helped us know what the benchmark was really. So if we were doing a monthly distribution, the logistics cost per dose and as a benchmark was just under 3 kwacha. And then in terms of staff, we were looking at the existing system giving over 50 full-time equivalent in terms of time. So we had 3 scenarios that we were looking at: scenario A, scenario B, and scenario C. Scenarios A and B had a bit of modification in that when you add 25% buffer at the province, it was slightly a different scenario. The same would apply to scenario B. Scenario A really was the movement from the district level to the health facility, encompassing mouth-stop distribution. Scenario B was a distribution from the provinces, again a mouth-stop distribution. Again, we can see both in terms of the logistics cost per dose and in terms of the health facility staff time spent on vaccine logistics, we can see the differences. For instance, scenario A had about 7% savings on the benchmark that we had, scenario B 11%, and then scenario C had an increase of 1%. In terms of the staff time, there wasn't much difference between the existing scenario and scenario A, but we did see that we only needed about 3 person full-time employment equivalent to deliver scenario B, quite similar to scenario C. In the optimized scenario, we did feel that scenario B kind of fit what we desired, with 11% of the savings if you deliver every month, 16% of the savings if we delivered by 2 months, and then that huge difference that we can see when we are looking at the current scenario versus the distribution using scenario B, as opposed to having 50 full-time equivalent personnel, we are looking at just about 3 of them. What we therefore did recommend is the scenario that gave us 9% less in terms of the cost per dose, the logistics cost per dose, if you compare the current scenario, and the one that we recommended, the optimized scenario, and also gave us a reduction in terms of manpower of over 94%. So this scenario basically is the movement from the national level to the province, but the province does a mouse-top distribution across all facilities. This led us to then think, that was about the supply chain, but I think we can do, and we thought we could, and we agreed really that we could do a bit more around the program. So we did have to package the improvements that I've spoken about on the supply chain together with the need for high demand or increased demand, but we also felt that some of the skills within health workers needed strengthening, and we also needed to improve the quality of data. So then the EPI Opt was born, or the EPI optimization was born, encompassing these 4 pillars, really with 2 main goals. One, meant to improve and provide a more equitable coverages, but also to have data within the API program that we were more confident with than existed within the current scenario. So what has been implemented so far and what have we seen so far is that we have the district pharmacists who have taken up the responsibility of doing this distribution from the provinces to the facilities. So what they do is they collect from the provinces, and then within a space of 2 to 3 days, they do the direct distribution within the designed mouth-stop loops in their districts, obviously ignoring the administrative boundaries. They also do provide supportive supervision during these visits. Basically, it goes beyond logistics. And then, of course, there is that healthcare worker exchange with districts that are doing well, so that there's cross-pollination of ideas. So this is happening in southern province of the country. This is the full map of Zambia, and we are doing this in southern province, 13 districts, which have been divided into 3 hubs. So we have the Lusaka hubs, Choma hub, and Livingstone hub, which is where the vaccines are kind of picked from. And the breakdown looks something like this. The first zone, zone 1, has 4 districts up north. The middle districts do form zone 2, and the lower 4 districts do form zone 3. And distribution is done around each of those zones with the predetermined routes. Preliminarily, we have a few results to speak of. What we've noticed is that, and the baseline speaks to 2019 December. Excuse me. So what we noticed is, for instance, that in terms of full stock availability in these health facilities, we were at just under 70%. In half a year, we've moved that to 91%. One of the remarkable movements has been the number of facilities that were conducting the physical counts, the physical stock counts in their stock. That has moved by 50 percentage points. We've seen a small reduction in terms of adequate stocks, which is defined basically how many facilities are holding stock between minimum and maximum. We think this can be explained by the fact that the supply chain is flowing without stagnation at the health facility. So with that rapid movement, even between facility and the point of service delivery, we tend to have more and more facilities having less between minimum and maximum. We've also seen that marginal movement in terms of the functional vaccine fridges in the positive direction. And we also have the physical counts that we find in the fridges matching the stock control cards, again, also moving by 50 percentage points. And then we have the submission of reports also moving from 71 to 97%. A few challenges have been faced. These include, of course, something we are trying to follow up and address, the late submission of reports. We still notice some gaps on average in terms of calculations and forecasting especially, which is part of the reasons that explain that reduction that I spoke of earlier. We've also seen some missing data, in some cases incomplete, something we are trying to address, particularly in the under 5 registers. We also feel that there's need to strengthen data verification and collection process at district level plus improve on communication across the district departments. Remember, this was one of the things we set out to solve. Lastly, we've seen some of the things that we didn't intend to do come out as spillover effects. One is that I think the districts have taken up this much earlier than we thought. We've also seen that the vaccine delivery is being utilized as a platform for supportive supervision, which has increased the presence of the program in health workers. We've also seen that there is integration starting to happen, particularly with the distribution of essential medicines and drugs. And also, we've seen that as opposed to a central transport system, districts are going beyond and also offering their own transport. Thank you very much.
Thank you so much, Dr. Mwansa. I appreciate it. It's great to see also the improvements that we see in Zambia. I also think it's really interesting to see the importance from both DRC and Zambia on the stakeholder engagement process, and to get buy-in and agreement and alignment on where it's going, and then to get the feedback loop along the way. Now we're going to hear from Olamide about some analysis that's been done for some system redesign in 3 countries. Go ahead, Olamide.
Thanks, Wendy. So I'm sharing results of the analysis, like Wendy said, in Madagascar, Guinea, and Niger. So just a little bit of background to supplement what Dr. Mwansa and Nkosi and Freddy have beautifully talked about. We define system design as an approach that analyzes and modifies supply chain components, including network, distribution, and the main purpose of that is just not for redesign purposes, but to improve availability and access to life-saving commodities at especially towards the child and the last mile. And it could range on the left with playing a game on a board, or on the right with innovating to distribute product at the last mile using drones and other technologies. And one of the assumption, or the major fundamental assumption, why we think system design approach is important, is because often, even though it goes missing and hides on that a lot of operations, the systems setup, the systems design is sometimes the barrier to performance improvements. Now we have several pillars, but we focus on 4 pillars that the approach rests on. One, it has to be evidence-based, including using qualitative and quantitative data to drive the approach. As you've seen from cases from Zambia and DRC, you need heavy investment of stakeholders. So it needs to engage national and also subnational stakeholders in driving this effort. It has to be context dependent. What would be progressive in DRC may be different from what is applicable in Zambia. Also subnationally, between counties or between provinces or between districts, there may be differences that needs to be adapted. And then supply chain is a means to an end. Oftentimes, supply chain folks are not given the right visibility because people think it's just operations, but supply chain also feeds the program. So ideally, as much as we want to see efficient supply chains, it's to, like Dr. Freddy said, it's to look back to program outcomes, including high coverage, including reduced stockouts, including equitable service delivery. So now overall, in working across countries with Wendy and others, we've identified some common alternative scenarios or system design scenarios that countries are interested in, or that are emerging from various countries. And you'd have seen examples of them in Zambia and DRC has presented. One is new product introduction. More and more, as the years go by, countries continue to introduce more and more vaccines. Also, we see increased performance in immunization as an opportunity to actually drive increased performance in other service delivery or other product supply chain. So integration is one of the pieces that's considered. Inventory holding points, including number of how do you map out your supply chain in a way that you optimize the capacity you have? And if you don't have some capacity or some cold chain equipment functioning well, how can you increase or decrease the storage capacities as you would have? And then the network between supply chain layers, transport operations, including direct delivery like you've seen in Zambia, and also delivery frequency like you've seen in those two countries, either reducing the increasing the frequency of supply, or actually spacing out frequencies is another way. Stock levels is also important. Oftentimes, countries would say we have static stock level across the layers, but more and more countries, even big India, are open to tiering their stock levels. And across all these alternative scenarios we're seeing supply chain interventions, including last mile delivery strategies using drone distribution, for example, including vial sizes, optimizing vial sizes and presentation. Some exciting innovations are coming out even with COVAX development. So an overview of the three countries we're talking about, we see that it's a bit wide range, from 12 million population in Guinea to about 26 million in Madagascar. To also coverage wise, you see that performance in Guinea is low, but you see that in Niger is 79% and Madagascar is about 75%. So you see that what should jump out from this should tell you that systems that can benefit all typology of countries. It doesn't mean because you have I-70s or peri-70 coverage that you can redesign your system to even get further. Even when you are up, when you are 90s, there's some equity challenges that's in your last 10% that could benefit from some form of redesign. So supply chain wise, you see these three countries also have different setups, even though their supply chain tiers could be a bit similar, from sub-central to region or district, and then to district or to L facility as you have. So you see either a 3-tier system or a 4-tier system, and we have the other number of regions and district there. So what were the system design scenarios that were prioritized by stakeholders in these countries? We saw, like I've stated earlier, in about more than up to 20 countries that we've been supporting with system design interventions, we see similarities. Also in Madagascar, Guinea, and Niger, what we saw as common, 2 scenarios were common to all 3. Change in delivery frequency. Oftentimes, we want to have less distribution down to the lower levels and increase the stock levels. That's number 1. Usually, oftentimes, you have a mix of either wanting to increase the supply chain tiers or reduce it. Oftentimes, there's a thinking around introducing a regional store and operationalizing it, even though sometimes that is costly, as you will see in some of the results later. Then optimizing network and delivery was these other scenarios. About 4 of them were common in at least two of the countries. Optimizing network using drones, which I think is exciting, especially in remote areas. Integration opportunity, like I talked about earlier, including using temperature-sensitive products, oxytocin, oftentimes considering other commodities to integrate with API, or integrating API into a broader supply chain system, as in Guinea, for example. And what is also common between Guinea and Niger was direct delivery, like you've seen in DRC and Zambia. So what were the indicators that were common that were used to communicate the results in this country? So 3 quantitative indicators and qualitative indicators, about 3 too. And some of them have been talked about by Zambia and DRC, so it's easier to talk about. Total supply chain cost, which is how much you spend on your supply chain. Cost per dose, which is just to look at your total supply chain cost over the number of doses you are moving. The cold chain capacity you have, how much of it you are utilizing. So the utilization of cold chain capacity, we think that's important, and you will see in subsequent slides. The augmenting these are the qualitative indicators, which looks at risk of mishandling products, because as much as you want to introduce into redesign into the system, you also want to position the system for success. You don't want to overburden the system. Then logistics burden on health workers, which you saw as an output from Zambia too, and then feasibility to implement redesign. So we go now to results from these countries, which I think is the exciting part. What are we seeing, so that we can think about what is coming out from those analysis. So here in the first slide, you will see results of annual cost, supply chain cost, and then cost per dose. So you see baseline on the left, which is usually the first bar there, and then you see about 5 scenarios compared to the baseline. So you will see that by monthly, and these scenarios are not mutually exclusive, by the way, they're just presented for ease of comparison and reference. But you will see immediately, like when you compare operationalizing regional stores with bi-monthly delivery of health facilities, which is the second and the third, you will see that the total supply chain cost for bi-monthly delivery is way lower than that for operationalizing regional stores. Also, if you see introducing 9 regional hubs, which is the 4th bar there, you see that that cost is high. But when you go to distributing across administrative boundaries, you will see that that cost is higher than by monthly delivery of 12 facilities, but it's still lower than introducing 9 regional store or using drones. And you see that drones is almost as expensive as baseline. So it almost appear as if you'll be having a doubling of your current supply chain cost. In all, you see by monthly distribution delivery of 12 facilities seems to be like the lowest cost per dose and lowest annual supply chain cost. What did we see in the qualitative results? So you see that the risk of mishandling seems to have a limited impact. It seems to will be impacted in a limited fashion. Of course, you would have expected it to be positive so that you would say, oh, there's no risk of mishandling. This would mean that stakeholders in Madagascar would have to pay attention if they implement all these scenarios to how much handling of how much health workers or human resources at the lower levels are handling product. Logistics burden on health workers. You see that if we implement it by monthly delivery, using of drones and distribution across boundaries, you will see that there's a lower burden on health workers at the last mile to do logistics responsibilities and duties. That means that you're freeing up time to actually see clients and deliver services to children and others. The feasibility of implementation is worse for bi-monthly delivery to health facility because that could need more investment, but it's neutral for introducing 9 regional. By the way, these are impressions from in-country stakeholders. So it's neutral for introducing 9 regional hubs and distribution across boundaries, but positive. And people look at it that it will be more feasible to implement operationalizing regional stores and use of drones. So if we go to Guinea, the results we're seeing again, starting with baseline on the left, the first bar, and also and going to the right, we see about 7 scenarios, and you can see how the cost per dose and the annual cost, which represent annual cost is the bar, and the line chart is the cost per dose. You see how varied. Not much difference here, but you see that integrating vaccines into 5 regional stores and establishing regional stores and ignoring administrative boundaries seems to be optimal or less costly and less cost per dose scenarios. Then going to the qualitative result, you see risk of mishandling actually is high across most of the scenarios, but for establishing regional stores, they seem it will be low, while direct delivery to from regional to health facility, it seems positive also. Also, logistics burden on health workers seems to be relieved almost across the scenarios with a neutral impact in about half, and then feasibility of implementation seems to be positive in establishing 4 regional stores integration, whereas the others have a neutral. That means there would have to be some work to be done before implementation takes place. In the J, of course, we have 5 scenarios, and you see eliminating district tier and adding another central store seems to be the one with low total supply chain cost and low cost per dose compared with other integrating, just pure integrating vaccine into the broader supply chain system, integrating oxytocin into vaccine, eliminating regional store or a mixed system or hybrid of this. And then for for the qualitative results, you see that there's the risk of mishandling seems to not be a major problem except in the mixed system, and positive for 2 scenarios, negative, neutral for 2 other scenarios. Logistic burden seems to be very, 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 very key here. We see positive impact all through the scenarios, whereas feasibility of implementation seems to be neutral almost in all scenarios, but mixed system would have to take more implementation time. And then coaching capacity, which I think is exciting result we're seeing across these three countries. We're seeing that about 50 to 80% of CC and L facility stakeholders, or they only use 5 or less than 5% of their capacity, which means that almost 95% and above of capacity at L facilities are not being used. Now, this speaks to efficiency. This speaks to optimizing the system. This speaks to how much the goal of system design as a whole is to optimize the system. So you see that this is quite exciting. There's hardly no health facility that you're seeing that is using more than 50% of their capacity. Now, what are the lessons that we're seeing, and also we're taking to other countries, and also informing implementation prioritization for Niger, Guinea, and Madagascar? Number one, like we've said, we have common system design scenarios. We're seeing that they're increasing consideration for integration. Integration used to be something that API API stakeholders don't even want to listen to, but we're seeing that more and more appetite is happening for integration. Just either way, either immunization, increasing performance of other products, or other products increasing performance for immunization. While cost implication seems to be important to stakeholders and partners, stakeholders or in-country stakeholders will continue to or desire to see more program-related indicators out of system design analysis. Like I talked about in the coaching capacity slide, low health facility capacity, low health cold chain capacity utilization in countries means that we're not efficiently using cold chain equipment that have been ramped up into countries. So it also has market shaping opportunities. Will this lesson inform what type of cold chain equipment are being manufactured for health facility, especially at the health facility level? That's important to see. And then stakeholder prioritization is important, but often takes a lot, has a lot of challenges to align stakeholders at different levels onto what scenarios to prioritize. And then these results that we see are exciting, typically exciting, but moving from that level, like you see in Zambia and DRC, to actual implementation involves matching this analysis with resource availability. And so oftentimes there's a mismatch in that. So of course, as partners continue to support countries, there needs to be that alignment of resource availability to when we have results of this analysis. So thanks for your attention. And this has been collective partnership with analysis done by GSI, with support of UNICEF, and financing by Gavi, and supporting these 3 countries. Thanks.
Thank you very much, Olamide, for that. It was a great broad view and analysis, and how analysis can help lead to decisions that Zambia and DRC kind of gave us some concrete examples of where to go with that.